We really started at the C-suite executive level and had deliberations with them about why this was so important to do and how it really aligned with the hospital's mission. From there, we brought the clinicians and the technical personnel together. So we really talked through what is the scenario for mapping the technology and how it would integrate with the hospital information system, and what are the clinical implications in terms of workflow.
So technology is huge because there's different aspect of technology involved here, IT, biomedical engineering, and also EHR. So all three aspects needs to work in seamlessly.
So one of the first things that you do if you're trying to build a financial use case is look at the timing that it takes you to do vital signs. I know that some units have had adverse incidents and they had claims, and that's your second block for the use case. So if you are carrying financial risk, there is a third building block. If you do things really well, you will need less intensive care beds, and you will probably have shorter lengths of stay because you're hoping to intervene earlier, and earlier treatment is most of the time more effective. So if you look at chief executives or the top people in your organization, one of the things that they understand very well is risk. And I think with the algorithm that we develop, we can define and explain risk much better than we used to. So they actually understand the risk.
When we started collecting the data and showed that this direct upload from the device to EMR helps reduce the transcription error, that was also another buy-in for our CFO. I showed him some of the evidence and told him, he could be one of those patient that had error and giving wrong medication, and he could be in, other than sitting there, and he kind of realized that no, he doesn't want to be one of those victims.